My theme today is about polycystic ovary syndrome. So the first is to remember that PCOS is a clinically and biochemically heterogeneous syndrome. It's a family aggregation, the heritability up to 70%, peripubertal onset, and it's a multi-etiologically. Uh, Let me do this, okay? So the classical definition is an endocrine metabolic disorder whose main pathophysiological basis is excess androgen production from ovarian and adrenal source, leading to dermocosmetic, reproductive, and metabolic manifestation. We are skipping through ovulation, hyperandrogenism, and polycystic ovaries to discover what is the diagnosis, what is the way to do a diagnosis of PCOS. It's the most common metabolic endocrinopathy in women of reproductive age, involves metabolic, psychological, and reproductive aspects. It's a frequent cause of infertility. It's the most common cause of hyperandrogenism. Up to 7% of affected women worldwide remain undiagnosed. It's a cardiovascular risk factor. Increased risk of endometrial cancer due to chronic ovulation and prolonged estrogen exposure. And finally, it's associated with obstetric complications like early miscarriage, gestational diabetes, hypertension, and preeclampsia. So the clinical expression is different in all the patients with PCO. It's an heterogeneity reality. So sometimes the patient is show us like hyperandrogenism between 48-70%. The menstrual irregularity is between 66-70%. The polycystic ovary morphology show us in 70%. The obesity is present in 80%. The lean patient is between 30-40%, and acanthosis nigricans is 2%. So all the patient express in different way. When we are talking about hyperandrogenism, so we need to think in hirsutism, in acne, and female pattern hair loss. The most often presentation is hirsutism, and is really the most important criteria to diagnose hyperandrogenism. The way to diagnose an hyperandrogenism, and special hirsutism, is using a modified Freeman-Gawain score. You can see a different diagrams here to show how is the dual scoring to know if the patient has hirsutism. So when you have a score more than 6, we consider there is a threshold for detect hirsutism. However, it's important to remember that the ethnicity the cutoffs of the ethnicity is different. For example, in Hispanic, Mediterranean, and Middle East women, we need score more than 9. However, if the Asian women, we need 2 or more in the score to discover that the problem of the patient is hirsutism. So this slide is to show you, so the Lowin scale is to do the diagnosis of female pattern hair loss. Here we can see a photos to a different expression clinical for hirsutism in different places. Here we can see a female pattern hair loss and acne. And the other important issue is about menstrual irregularity. So only 66% of patients have menstrual irregularity. So the patient had normal menstruation in 30%. So the oligomenorrhea is the most often clinical presentation in 47%, amenorrhea, polymenorrhea, and menorrhagia is only 1.4%. So difference irregular menstrual irregularity, it means possible to PCOS. This is the aspect when we are doing an ultrasound, transvaginal ultrasound, you can see a lot of follicles. This is an aspect to the surgery, and this is the aspect in histology tissue. So the ask really is really a polycystic ovaries? So it's very important to understand this, because these are actually follicles arrested at different stages of maturation. Are not true cysts, and it's important to explain this of the patient, because the patient is worried about, oh, I have polycystic, so it's cancer, I need a surgery. So I need to explain the patient to be more relaxed about the diagnosis and what is the means of your pathology and what is the treatment that the patient needs. Depends of the disease that have in this moment. This slide is to show you what is the way to the follicle growing. So the follicle antral is start to growing and the ovulation, and finally the luteal phase, we can see a corpuluteum. We can see a different levels of estradiol and progesterone through the cycles, and these different levels means different thickness of the endometrial thick. So in the first time of the menstrual, you can see a really line. The thing is low and is growing until window of implantation. And finally, when the levels of progesterone is low, so the endometrial is breaking and you have a menstrual period. However, in the patient with anovulatory cycles in PCOS, so the follicles start to growing and stop, start to growing and stop, start to growing and stop, and we can see a clinical typical image by ultrasound. And the estradiol is continually high, and this is the reason that the endometrial, the thickness of endometrial is higher, and this is the explanation about the risk of hyperplasia and cancer. The other clinical expression different is anacanthosis nigricans. You can see an hyperpigmentation on the nape of black and on air tips here, are tips. The heterogeneity is the same in biochemical expression. All the patients with PCOS had a different levels of different hormones. For example, the testosterone is high in 50% of patients, LH is in 40% patients. The radio of LH FSH is 90%. So the LH is higher in the lean women, especially in the lean women. The prolactin is high in 11% with PCOS. The DHEA is high in 33%, and 70-hydroxyprogesterone is in 20%, and insulin resistance is high in 50%, and especially in the women that have obesity. However, in the lean women, we can see an insulin resistance, and it's very important to, in all the patients with PCOS, we need a metabolic screening. So the PCOS diagnosis is doing based on technical report for the International Evidence-Based Guideline for the Assessment and Management of Polycystic Ovary Syndrome, updated on 2023. It's based on the Rotterdam criteria in 2013. So there are different criteria to do a diagnosis of PCO. However, we are recommended Rotterdam criteria. So in this point, the prevalence using this criteria is between 14 to 19 is the prevalence. Approximately 74% of patients with PCOS are anovulatory. About 30% of infertility patients are anovulatory, and 90% of these cases are due to PCOS. It's the most often endocrinopathy in the women. The diagnosis criteria include 1, oligoanovulation, 2, clinical and biochemical hyperandrogenism, and 3, polycystic ovary morphology of increased levels of anti-Mullerian hormone. So you can discover that level AMH is included in new classification to diagnosis. However, we have a problem with the cutoff, and I will explain you in the next slides. So we need 2 of 3 criteria to do a diagnosis. However, it's very important to remember that the diagnosis of PCOS is an exclusion diagnosis. We need to have an exclusion for other causes like hyperthyroidism, hyperprolactinemia, congenital adrenal hyperplasia, and we need to know if the patient having amenorrhea to do IFSH, or if clinically indicated, exclude another causes like hypogonadotropic hypogonadism, usually due to low body fat or intensive exercise, should be excluded clinical and with LH and FSH levels. When we are doing these criteria, we understand that we have four different phenotypes. So hyperandrogenism, polycystic ovary morphology, and chronic anovulation. When we have all the criteria, we are in front of phenotype A. When we have hyperandrogenism plus polycystic ovary morphology, we have in front of phenotype B. When we have hyperandrogenism plus chronic anovulation, we have a phenotype C. And when we have polycystic ovary morphology plus chronic anovulation, we have a phenotype D. So the most often phenotypes is A and B, is between 40 to 70% of the patient. And in this way, when we have hyperandrogenism, it means that the metabolic diffusion is higher than the patient who have phenotypes D. So it means that the hyperandrogenism is really the most important in the metabolic diffusion. The patient have more obesity, insulin resistance, higher triglycerides, low HDL cholesterol, and more metabolic syndrome. When we are talking with a hyperandrogenism in clinical, it's hirsutism, acne, female pattern hair loss. And when you are thinking that it's necessary to explore if the patient have a biochemical hyperandrogenism, we need to require total testosterone, sex hormone building globulin to calculate a free androgen index. The free testosterone have really problem because the special test that do in the lab, so it's more difficult really to take a cutoff of the levels of free testosterone. So this is the reason that the guideline recommends use a total testosterone plus sex hormone building globulin to calculate a free androgen index. If we are thinking really that the patient had an hyperandrogenism, and this test is normal, it's time to request androstenedione and DHEAS. When we have testosterone, total testosterone more than 150 nanograms per deciliter, we are thinking in tumor, in a special ovary tumors. And when we have DHEAS more than 6,000 nanograms per milliliter, or more than 700 micrograms per deciliter, one need to think in tumors with the adrenal. Isolated hirsutism should be considered predictive of biochemical hyperandrogenism on PCOS in adult women. However, isolated female pattern hair loss and acne in the absence of hirsutism are relatively weak predictors of biochemical hyperandrogenism. It's very important to remember that the potential negative psychosocial impact in the patient who has this problem, and it's important to explain with the patient and in sometimes to refer to the psychological treatment. When we are doing a biochemical evaluation, the assessment of biochemical hyperandrogenism is inherited by the lack of clarity regarding which androgen should be measured, which assay should be used, how normal reference range should be defined, given the overlap between values observed in women with PCOS in controls, as well as issues related to test availability and cost. Total testosterone alone identify approximately 20-30% of women with PCOS, whereas measure of free or unbound testosterone identify about 50-70%. So the way to identify unbound testosterone is doing a free androgen index. The way to calculate is using this formula is total testosterone in nanograms per milliliter multiplied by 3.47, and this result divided by the level of sex hormone building globulin, and this result plus by 100. It's normal when this index is less than 4.5. When we have levels or index more than 4.5, we are in front of hyperandrogenemia. When we are thinking in patients with PCOS, the assessment of biochemical hyperandrogenism has greater diagnostic value in patients with minimal or absent clinical signs of hyperandrogenism. So remember, we are thinking and we need to full know two criteria of 10 criteria. For example, if we have only one criteria, for example, hyperandrogenism, and if the policy is no appearance of polycystic ovary morphology, we need to think that we need to do a biochemical test. However, if we have PCO morphology, and we have an acne on hirsutism, we don't need to take this test because we are really have the diagnosis. Only if we are thinking that we have a different problem, like a tumor, for example, we can ask or require about the different biochemical test. In women using combined oral contraceptive, this should be discontinued for at least 3 months prior to testing. Remember that the contraceptive pills avoid the morphology of PCOS. So if we are trying to looking for the diagnosis, we need to stop these pills. The androgen levels reach adult reference range between 12 and 15 years of age. So the problem in sometimes is to do a diagnosis in the adolescent patients because the adolescent patients have a really great ovaries, a great quantity of follicles, and it's normal. It's not PCOS. So in this point, we need to classify like a increasing risk to develop a PCOS after in their life. So in this point, we need to wait until reproductive maturate 8 year post-menarche. When we are talking about menstrual disorder, the menstrual disorder is characterized by oligo or amenorrhea caused by infrequent or absent ovulation. Menstrual abnormality usually begin at puberty. Irregular menstrual cycle is defined as normal during the first year after menarche. Between 1 to 3 years post-menarche, cycles less than 21 or more than 45 days is irregular. After 3 years post-menarche until perimenopause, cycles less than 21 or more than 25 days is irregular, or if the patient fewer than 8 cycles per year. Or if the patient have 1 year post-menarche, more than 1 year post-menarche, any cycle more than 90 days is a regular cycle. Primary amenorrhea is defined like absence of menstruation by age 15 or more than 3 years after telarche. I really love this slide because this slide shows us all the different levels of the hormones through the ovulation cycle. So in this slide today, really I want to show you that we need to require progesterone between day 21st, 22nd, because this is the special day that is the higher level of progesterone. And if we have level more than 3 nanograms per milliliter, we can see that the patient is ovulating. However, levels between 3 to 8, it means possible that no very good ovulation is better when it's more than 8 nanograms per liter. However, the definition is more than 3. The other way to diagnose ovulation is doing an LH kit, starting in the 11th day of your menstrual period, and when we as a mark positive, we can discover that the ovulation is occurred. The way to discover a polycystic morphology is using a transvaginal ultrasound is better. However, sometimes we need to do a transabdominal ultrasound in patient that is not intercourses. The way to get the criteria is when we have more than 20 follicles between 2 to 9 millimeters in at least one ovary, follicle number per ovary, or when we have more than 10 follicles per cross-section in at least one ovary, follicle number per cross-section, or ovarian volume more than 10 milliliters in at least one ovary on transabdominal ultrasound. Remember, there are no definitive ultrasound criteria to define polycystic ovary morphology in adolescents. This slide shows us a special image for polycystic ovary morphology. We need to talk about AMH hormone in this guideline. So the guideline is try to introduce the AMH to do a diagnosis. However, the problem is we don't know cutoff point has been established, as they vary according to age, ethnicity, and test usage. However, the guideline tried to explain you that the best level is more than 3.2 nanograms per milliliter. However, it's not really a cutoff defined in the wide world. Sometimes the report is not in nanograms, it's in picomoles. So this is the reason I want to show you the equivalence note. It's 2.1 nanograms. The equivalence is 15 picomoles. The AMH is recommended in patients who do not meet the full diagnosis criteria. So AMH should not be used as the sole diagnosis test for PCOS. And the serum AMH should not yet be used in adolescents. Remember, it's a diagnosis, an exclusion diagnosis, and we need to have in mind hypothyroidism, hyperprolactinemia, congenital adrenal hyperplasia, hypogonadism, hypogonadism, Cushing syndrome, androgen producing tumor. We need to ask all the patients that are taking exogenous androgen intake, Hayden syndrome, or idiopathic hirsutism. We can start with required TSH, prolactin, 17-hydroxyprogesterone, sometimes FSA, depending if the patient is in amenorrhea. And if the patient, we don't have a lot of criteria to do a PCOS diagnosis, we need to require total testosterone plus sex hormone globulin, binding globulin. When we are thinking in congenital adrenal hyperplasia, remember that the normal level is less than 2 nanograms per deciliter. Values more than 8 nanograms per deciliter is a diagnosis. However, when we have levels between 2 and 8, we need to do a test with stimulation with ACTH. We need to use in 250 micrograms intravenosus for colchicine is the name. And the values more than 10 nanograms per deciliter at 1 hour after injection of 17 alpha hydroprogesterone is diagnosis. When we are thinking in Cushing syndrome, we need to require or free cortisol in 24 hours urine or cortisol AM. So we only require test for Cushing syndrome when we have a stigmas of Cushing syndrome. So the level of abnormal level of free cortisol in 24 hours urine is more than 90 micrograms per deciliter or 2. This deviation is standard above normal. If the cortisol AM is abnormal, we need to do a ovarian suppression test with dexamethasone using 1 milligrams at 11 p.m. the night before and take in the next day, in the morning. And if the level is less than 5, is normal. If it is between 5 to 10, we need to do a free cortisol in 24 hours urine. Or is more than 10, we have a diagnosis of Cushing syndrome and then look for the cause. Sometimes dexamethasone is not available. For example, in Colombia, sometimes it's difficult to get this. And we can use a delta fluorine, 0.75 milligrams, or prednisone between 5 to 75 milligrams. Every patient that we have a diagnosis of PCOS, we need to do a metabolic screen. When the first criteria, the diagnosis criteria in 2013, so it's not included to the metabolic screen in the patient that are lean. However, right now is all the patient with diagnosis because PCOS is a high cardiovascular risk. So you know the cardiovascular event is between 1.5 and 4.5 times higher. Myocardial infarction, angina, needed for revascularization, hypertension is between 10 to 4% more higher, times higher. The activation of the RAM system, sympathetic excitation, reduces of nitric oxide bioavailability, non-alcoholic fatty liver diseases more often, overweight and obesity, anxiety, depression, disordered eating, obstructive sleep apnea, dyslipidemia, insulin resistance, prediabetes, type 2 diabetes, metabolic syndrome, and endometrial hyperplasia and endometrial cancer. So this patient, sometimes in our case, is looking for the pregnant. So it's very important to remember the obstetric complication, recurrent gestational loss, gestational diabetes, pregnancy induces hypertension, preeclampsia, preterm birth, intrauterine growth restriction, increase in prenatal morbidity and mortality. The way to evaluate these risks, is doing in step one, taking a weight and BMI assessment. The second step is to glucose screening. So every 3 years, we need to take oral glucose tolerance test or fasting glucose or glycosylated hemoglobin. If the patient is with PCOS and another diabetes risk factors, we need to require oral glucose tolerance tests between 1 to 3 years. And all the patients that are looking for a pregnant, we need to take oral glucose tolerance test and repeat when we have been pregnant in the early pregnant, and repeat between 24 28 weeks of pregnant. The step three is check blood pressure annually. The fourth step is a lipid screening overweight and obese women at diagnosis and repeat based on risk. And this guideline introduced and to study of obstructive sleep apnea should be considered, screened by questionnaire and sleep study if needed, and treated only in symptomatic patients. And the endometrial cancer, is a really risk. However, is not recommended as screening by routine. However, all of ones decided to do an ultrasound in all our patients. So I think that is very good, a very good working with the patients. When we are think in treatment of PCOS syndrome, we need to ask if the patient is the symptomatic treatment or the patient is looking for a pregnant. So the main stone is life change in both. However, if the patient is not looking for a pregnant, we need to treatment the symptoms. And if the patient is looking for a pregnant, we need to do ovulation induction. The reduction between 5 to 10% of weight reduce the insulin resistance, reduce the insulin level, reduce the free testosterone, reduce the IGF-1, and increase the sex hormone building globulin. All of them is to improve the ovulation, improve the pregnancy rates, reduction the ovulation requirement, and reduction of metabolic complications. The guideline show us that the first line of pharmacological therapy is using contraceptive pills, plus lifestyles, of course. So the contraceptive pills, we need to start with the lowest effective estrogen doses, between 20 to 30 micrograms estradiol or equivalent. We need to consider natural estrogen preparation, balancing efficacy, metabolic risk profile, side effects, costs, and availability. It's very important to have in mind the follow of WHO that using contraceptive pills to discover the absolute contraindication and risk. Please avoid using cyproterone acetate. Remember, the cyproterone acetate have more risks in this patient because the metabolic profile is worse, and especially in these patients. And the doses is 35 micrograms, is higher than the recommendation to use between 20 to 30. When we are thinking in what is the best contraceptive pills to use, is no preparation is superior in PCOS. However, it's very important to have in mind the difference profile of different progesterones. For example, tenohest, for example, clormadinona, for example, drospirenona. Sometimes it's better in the patient with hyperandrogenism, and your metabolic profile is better, for example, the Enogest or clormadinona. The mechanism of action of contraceptives It's a negative feedback to the hypothalamus and pituitary gland. It means that it inhibits ovarian and adrenal steroidogenesis. They increase sexual hormone binding globulin, and they inhibit 5-alpha reductases. We need to check the response between 6 to 12 months. We need to do evaluation, clinical and biochemical, the treatment for 2 years and evaluate, suspend, or maintain low doses. If no clinical or biochemical improvement, we need to reevaluate the cause. If no clinical improvement despite biochemical improvement, we need to increase doses or add another anti-androgen. So the second line of pharmacological therapy is, lifestyles, contraceptive pills, plus metformin. So the metformin really is indicated when we have adults with a risk, cardiovascular risk or metabolic risk, or if the patient have more than BMI more than 30. When we decided to do anti-androgens is when with the patient is no response with the contraceptive pills and a lifestyle indication. In this point, we can start, for example, with aldosterone or start with cyproterone plus contraceptive pills. Sometimes we decided to start with metformin plus lifestyle. So the metformin is really important in the patient we have metabolic risk or have more than 25 BMI, more than 25. We need to remember that the gastrointestinal effects explain that we need to start with doses, low doses, starting with 500 milligrams for 1 week and try to high more doses weekly until reach until reach 2.5 grams in adults and 2 grams in adolescents. Remember that we need to check vitamin B12 because sometimes the metformin is associated with low levels of vitamin B12. When we are thinking in inositol in any forms, we can consider the use of this medicine in any forms. Sometimes it's alone inositol, sometimes it's inositol, or sometimes in a different quantities of the preparation. And we can really do it because it's a limited harm. And we know that reduced biochemical hyperandrogenism and metabolic measures with limited clinical benefits for ovulation, hirsutism, and weight. However, we know different studies to show us that benefits in ovulation and hirsutism. When we decided to do anti-obesity agents, so the special agents, it's GLP receptor agonists like liraglutide, for example, or semaglutide. So this management is only for patients with higher weight in adults with PCOS or in a general population according with the guidelines. We need to start with a low doses. We need to avoid the pregnant using an effective contraception. The risk is high to regain weight when the patient discontinue this medicine. And finally, when the patient is thinking in fertility treatment, we need to optimize preconception health and lifestyle to avoid a complication in the pregnant. And in the first line medical treatment is using letrozole. The letrozole is starting 2.5 milligrams, increasing doses as required. So if you can get ovulation with these doses, we can continue until 6 months using the same doses. If we don't get the ovulation, we can increase the doses in the next cycle until 5 milligrams per day for 5 days. And continue, and we can get the ovulation, we can continue until 6 months more. Sometimes we can decide to start with clomiphene plus metformin. So clomiphene alone or metformin alone is good, however, it's better the combination. So if you are thinking in use metformin or clomiphene, please use it together. And we decided to use metformin when we have insulin resistant and metabolic risk, or we have BMI high. In the case that we don't get ovulation, we can change to the second line medical treatment. In this point, we need to start with gonadotropins. Gonadotropins is a really good medicine, however, need a lot of monitoring to avoid a multiple pregnancy and avoid a ovarian hyperstimulation syndrome. So it's very important to start with a low doses and doing more doses each 7 days to get only monofollicular development. In the case that we have ovulation, we can continue in the next month until 6 months using the same doses. If we can get the ovulation with these strategies, we can consider laparoscopic ovarian surgery. However, I need to tell you about my experience. So I had two patients with a premature ovarian failure when we decided to do this procedure. So I don't recommend to do this procedure. And if we don't have ovulation with gonadotropins, we need to skip to the third line medical treatment. In this point is ABF. So finally, this history will continue when we meet to talk about the PCOS patients' fertility treatment in ovulation induction in low and high complexity, virtual or in our hands-on experience on Trinidad on the next June. Thank you very much.
All right. Thank you so much, Dr. Lopez. That was a really informative and comprehensive talk. Um, I'll open up the floor for questions, but in your experience, what's the incidence of PCOS like in Colombia where you are?
I think it's really is high. So we have a lot of patients with PCOS. I did surprise it. So a lot of patients with are lean.
Mm,
It's
PCOS.
incredible. Yes, lean PCOS. So I think it's more than 20% really. So we have a lot of patients with this.
There's been a lot of talk recently about treating lean PCOS as its own phenotype, right? What are your thoughts on that?
So about the phenotype A.
Yeah, the phenotype A. Okay. Yeah.
Yes, A is the most open is phenotype A.
Mm-hmm,
So
mm-hmm,
sometimes it's difficult to do for example, when we have phenotype D, sometimes the
mm-hmm.
doctor considers, oh no, it's not a PCOS. No,
Yeah.
it's a PCOS. It's very important to understand the hyperandrogenism is important because it's
Yeah.
a risk factor, right?
Mm-hmm, mm-hmm.
However,
Yeah.
so with phenotype D is a PCOS.
Mm-hmm. Yes. We have one question about the dosage of letrozole, about what's the starting dose and how you titrate up and how often. The lowest dose is 2.5. I typically start at 5 milligrams. What are your thoughts on that?
Yes, so the guideline recommend to start to 2.5.
Yeah,
So
sure.
really, I start every time we fight, right?
Yeah, okay, fair enough.
However, you can
Mm,
see a lot of
mhm,
studies show us that different
mhm,
results starting with 2.5 and 5 milligrams per day. So it's
mhm.
the same. It's the
Yeah,
same, really, right? Um,
gotcha.
so we need to start with 2.5. If we
Mm-hmm.
don't get ovulation in the next cycle, we can use 5 milligrams, and we can get ovulation. We use the doses to 7.5 milligrams. And if you can get it, you need to change the strategies,
Sure,
right?
sure. Yeah. And another one, I guess, would be how long do you recommend treating a patient with PCOS for infertility as a generalist before referral for IVF? Do you put a fixed timeline on it, or is it sort of like a case by case situation?
Okay, it's a very good question. It's a very good
Mhm,
question. So we need to talk with the patient
mhm,
in a different way about, for example, the semen sample, the
mhm,
tubes, the available to do the monitoring ovulation induction.
Mhm.
Uh, uh, I need to talk with the patient about what is the preference about the only ovulation induction, or he prefers to do a ABF. Sometimes the patient decided to
Mhm.
start in the first time with the ABF. So it's very
Mhm.
important to be a very good dialogue with the patient to discover what is the option that the patient has.
Sure, sure. Absolutely. Right.
However,
Mhm.
every time it's important to explain to the patient,
Mhm.
okay, when we are balancing the risks of benefits, it's better to
Mhm.
start only
Mhm.
with an stimulation if everything is well,
Yeah.
right?
Yeah. Yeah.
Yeah.
And how do you do laparoscopic ovarian drilling? Do you, I know some providers do like a fixed single point and burn for 10 seconds, and there's other guys who believe in 10 to 12 injections per ovary.
Okay, yes, I want to tell you. So I think that the laparoscopic drilling is pretty
Mhm.
good. So
Mhm.
when you decided to see to read a lot of benefits to use it, okay, it's really
Mhm.
good. You only
Yeah.
need to do one procedure, and it's
Mhm.
possible that you have in more than 50% of patient ovulation spontaneous ovulation. Oh, it's
Mhm.
great. You need to use a special technique to
Mhm.
avoid
Mhm.
premature ovarian insufficiency and to
Mhm.
avoid additions.
Right.
However, I do patients, I had patients, and I did this procedure to patients. And finally, the end was in premature ovarian failure. So
Yes.
I decided to avoid this
Mhm.
surgery because
Yeah.
I care about this. I'm
Mhm.
worried about this.
Absolutely.
However, the line explain us that you can do it. I tell you my experience.
Yeah. Yep. Absolutely.
There- Are there any more questions that you would like to ask to Dr. Carlos Lopez?
Um, Looking through the chat, I guess I'll
No,
wait for 5 more
we don't
minutes,
have,
but I don't think we have a lot
yeah,
of
we
questions
don't have
coming
more.
in.
Well, meanwhile, thank
Mm-hmm.
you all for joining us today. This
Mm-hmm.
was a wonderful lecture, Dr. Carlos. Thank you so much. And just a reminder that we will have our final lecture for this cycle next Thursday at the same time. And we will have Dr. Sergio Tamayo talking about managing the infertile patient. So we have walked through the whole process, and what we want to do is the closure to let you know how we can manage the infertile patients and how we can direct them to our specialist. And the other reminder is that Dr. Susana Salazar will be in Trinidad next week. She will be from Tuesday and until Friday, and we will have their two live sessions. And there, if you want to join us, let us know. We will send a form so you can register. And what we will do there is solve any questions that you have in regards of the lectures that we have had in the weeks before.
Absolutely. So yeah, just to reiterate, that's this Thursday at 6 p.m. Trinidad time. We have our next lecturer, Dr. Tamayo. And the live sessions are next week, so just around the corner, guys. It's the 24th
That's
and the
right.
25th, right? So yeah, we're all really looking forward to it. And there will be another series of lectures in May. And I'm gonna post the dates and the timeline for that later on.
Okay.
Yes. All right. Thank you so much again, Dr. Lopez. I don't think there are any more questions, so I guess we can close the session there. Thank
Uh,
you for your time and for your expertise and for a very thorough and informative lecture.
oh, it's a great pleasure. I see you soon on June.
See you soon. Have a good one.
Okay,
See you
bye.
Bye-bye.
soon,
See
Thank
and
you
you,
thank you
Dr.
so
again.
much for
Persad.
joining us.
Thank you,
Bye.
Catalina. Thank you, Carolina.
Bye.
Bye-bye.
Bye.
Cata, listo.